Welcome to Burning the Couch with Pim and Micaela. Although we are licensed therapists, please note that information in this podcast should not replace psychotherapy, clinical supervision, or be taken as legal or medical advice.
Privacy is important to us, so all people, places, and scenarios mentioned in this podcast have been changed to protect client confidentiality. Also, we don't condone literally burning your couch. And a special thanks and shout out to C-Cop Studios for the awesome music we're using in this podcast. Welcome back, everyone, to Burning the Couch. We have a special guest today, a good friend of ours. Her name is Kristen Ackerman. She's a master's level marriage and family therapist in California here. And we're going to talk about some of the work she does. She's been doing a lot of community mental health, which Pim and I have spoken a lot to private practice, but we're going to get a little different perspective today.
Yeah. Hi, Kristen.
Hi.
So good to have you on our show. Why don't you just maybe introduce yourself a little bit to our listeners of some of the places that you've worked at, maybe not their names, but the type of environments and what you did at those places?
Yeah. So I initially did my traineeship at a kids psychiatric hospital in the outpatient division. And then once I completed school, I then got a job at a community mental health program. It's outpatient adults, so it was 18 and up, and I've been doing that. Well, I don't do it anymore, but
You're there for a long time, right?
Yeah, I started in 2016 and I recently left, so
Yeah,
a couple of years.
Quite a long time. Actually, Kristen, Micaela, and I used to all work at the same children's hospital. It's not Children's Hospital, by the way. Had to make that clear. But we were all like in the same hallway, and it was so fun because Kristen was next to me and Micaela was right across from me. And like whenever one of the kids would have a big meltdown or something, we would all hear it. We would all hear it. And like if someone had a crisis, like we would all know, because we would have to like do our protocols and whatnot, and we had our lunch dates, so it was super fun. We've definitely known Kristen for quite some time, so I hope this episode will be interesting for you all, so you get to hear a different perspective than just from the two of us. Well, Kristen, I want to start with asking you, like, what got you interested in doing the work that you do in the first place, like specifically like the place that you were at and doing community mental health?
I found that in my traineeship, I really liked kind of working with more high-risk individuals, and I liked working with like upper adolescents, and so I kind of wanted to look for a job that was somewhat similar, and so I found myself looking at community mental health because I knew I'd be able to work with the job that I went to. I specialized with 18 to 24-year-olds, that I could work with kind of a similar age range, and also worked with individuals with more complex situations and more crises. I was just drawn to that initially.
What sort of things were you seeing there? Like, I know there's crises and high risk, but was it like a substance use kind of thing? Was it severe mental illness? Like, what kind of disorders or challenges did you see?
Yeah, it was severe mental illness, and majority of our individuals that we worked with also had a co-occurring substance disorder as well. the program that I specifically worked at, your primary diagnosis had to be mental health. It couldn't be substance use.
Okay.
For whatever reason, the county we worked in had us differentiate that, even though I think personally they go hand in hand with one another. It's really hard to differentiate the two of them at times.
Right. And it's like Medicare or uninsured, right?
Yes. So we worked with people who were Medi-Cal, some Medicare if they had like Medi-Medi, and then uninsured individuals. And usually we'd work with those who were uninsured to help get them the Medi-Cal. And then we also had to take into consideration their income. So even if they had Medi-Cal, but they made a certain amount of income, they could potentially be have to pay a smaller fee, like at the end of the, like on a yearly basis. But I never personally had to deal with that. That was like more on the insurance side that we didn't really, I don't know, whatever came of that.
Yeah. And so that kind of brings us to kind of another point here is you've had several different roles within community mental health. Can you speak to a little bit about that, what you did there, and the difference between the positions?
Yeah. So I got hired on as a therapist, but like a lead therapist position. So how do I explain it? I just had more of like a leadership role. I took on more responsibilities and duties in that role. So I would have more high risk clients. I had more groups. I was more involved in the training process. I did more of like the coordination of care with different community providers, like community colleges and like Job Corps. So I did that for, it's a little confusing because I went back and forth between roles a lot, but a couple of years. Then I was in the acting role for strength-based case management. Their program, what was the title? I don't remember the title, but I was like head of the strength-based case management program. So we had like the outpatient program, and then we had within it strength-based case management as well. So like some people would be like kind of like dual enrolled, so to speak. So I was head of that for a couple of months as well. That was probably like my least favorite role. But it was mostly trying to help staff schedule for success and reaching out to the community, going into the community. So that was more of like going to where the client was at versus them coming to us. Okay. So we would go to doctor's appointments, into their homes, and into the community at like Starbucks if it was like in a secluded area, and with consent, of course. Driving clients to the DMV or to SSI, that sort of a thing. And then I've been in the assistant director role. So I've been at two different programs and they operated a little bit differently. But I just supported the program director, and a lot of my roles was reviewing documentation, training. I was a point of consult for high risk needs, although I was always in that role as well. I just had a higher say, so to speak. If like we were to determine that confidentiality needed to be broken, I would be like the one that say like, yes, we can. And then I've also been in the acting program director role where I was in charge.
So many roles.
I know.
Yeah. And it sounds like there's a lot of work that wasn't necessarily like therapy, like directly providing therapy to the clients. And you're either doing more like case management work, being a chauffeur, those kind of things. And doing the more like behind the scenes of what it takes to run a program like that.
Mm-hmm.
Do you find like pros and cons between like doing like therapy work versus like being in a mental health position but not doing therapy, like
Right,
doing
more
more
management.
management?
Yeah.
Because I think like, like in school, right? In grad school, everyone's learning like the theories, everyone's learning the models, like how to provide therapy. But when
Mm-hmm.
you're actually out in the field, there's so much more to therapy work or mental health work than just being a therapist, because there's people in that has to fill these positions and these roles. People who write grants, people who do outreach, or therapists who teach, for example. So I want to get your perspective on that piece.
Yeah. So it's there's so in community mental health, there is room for like traditional therapy to some extent, but maybe not a lot of the theories that we learned in school. So we gravitated more towards like CBT and DBT because those seem to be most indicated for the population that we were serving.
Plus,
And
the
then,
county likes that.
yeah, and the county likes that slash somewhat requires it. We had to use the evidence-based practices in our documentation. It had to be very clear. In the program management role, we weren't taught about that in school. And so it's something that you kind of just had to learn, but also maybe naturally have a knack for, I think. And I did enjoy it. Like what I really enjoyed was also like a downfall for me eventually, just due to natural like burnout. Um, but there are pros. I mean, you learn to really get a feel for knowing when you cannot, break confidentiality. Like you fine tune some of like the law and ethics components. Um, and you get to kind of fine tune kind of a supervision if you're looking into like maybe like a supervision component, because a lot of it is you're watching over what everybody's doing and you're responsible for what everyone else is doing because everyone else below you is not licensed. I don't know if that answered your question or not, honestly.
Yeah, no, it did. And so with like the managements, I mean, can I ask you personally, do you enjoy like management or therapy, like one more than the other?
Yeah. I do love therapy. And that is why I went into the field. Like I didn't go into community mental health being like, I'm going to
Be a
progress
program
to the management
director.
role. Like that was not what went into like that was not the plan whatsoever. It was just like things fell into my lap where I was able to grow within the company to get to where I was. And um I did really like management. I do still. I think that so I've been at two different management programs, and I think that in order to be in the management role and to be successful in it, you cannot be carry a caseload.
Hmm.
So what I think was the most challenging and what kind of led to my downfall and why like I kind of grew out of management was I was still case carrying.
Right.
In the assistant director role, I carried high risk clients. I had a couple therapy clients. I dealt with crises when needed. And so it's really hard to be in a therapy session. I was doing air quotes as if you can see them.
It takes time getting used to having to like describe everything that you're doing visually, but in audio. I know.
So like I would be doing my therapy sessions or working with, I don't know, I was doing something with a client, and then I would have people via like our encrypted like Skype or Teams, like Skyping me to consult about like another safety issue. And so that's where it got really complicated, where like I'm trying to give my focus to one person and
you can't be present
on a safety issue. So I can't be present with one person and present with it just, and that's where my kind of not distaste or maybe even like resentment towards management started to come from, was like having a dual role when we shouldn't be in a dual role. But I mean, there are.
No, I think that's honest. I think that's very honest. And it's more of a systemic problem that we have, right? Because a lot of these programs are underfunded, and that role, the position that you had clearly had to have been a job for two people.
Oh yeah.
Maybe even more.
Exactly. Because these programs are so underfunded, and that's what ends up happening. And then you have like high turnover rates and people not being able to stay there long because they're so like burnt out from their position. Can you talk? Sorry, Micaela, go ahead.
So I was just going to ask, you had mentioned, because it is hard and it is a high burnout rate. And you said, to be in more management, community mental health, you have to have kind of a knack for it. What kind of qualities or even piece of advice for people who are interested in that route would you recommend, or would you think would benefit in that kind of role?
I think you have to be somebody who is able to really think through what's going on in a like very meticulous way. Like you have to, like if say you're presented with like an issue, a safety concern, and you have to be able to think through the laws, the ethics, the client's well-being all at the same time. So you have to be just very like on your toes.
Very diligent.
You have to be able to make really important decisions pretty quickly at times, because oftentimes if one crisis is happening, there's probably another one, because that's the way it works. So you also have to be somebody who, because a lot of it was also like reviewing documentation and helping staff hone their own therapeutic skills. So you have to be diverse in knowing different therapy modalities and being able to write clinically as well. So if you have good like writing skills, or clinical writing skills, I guess you should say, and
which that in itself could be very different if someone's coming from a private practice kind of standpoint and has never had to document in community mental health positions. That might be a shift and an adjustment too, right?
The system we used, at least, was not very user friendly. It required a lot of different components that were often a little bit repetitive as well. Documentation took a very long time, and it was very meticulous because the county audits also required certain things as well. So you couldn't miss certain specific things in it. You also cannot copy and paste or make it, or like, a client sounds, they're presenting as depressed and not making eye contact and kind of fidgety in their chair. If they're presenting that way one week and the next week, you cannot write it the same way, even though they're presenting the exact same way, because their county is going to view it as
you're copying and pasting
your documentation, even though, you're not, that's not your intent at all. So
I remember having like when we were at that children's hospital together, I remembered I'd copy and paste and like change like 4 or 5 words just to make it sound different.
Yeah. Another quality that you have to have in the management role is like, you've got to be organized. Like, besides being oversight of everybody in the program, you're also running, depending upon what role you're in, you're doing reports for the county, reports for the company. You're doing, there's county deadlines that you have to meet. There's the company's deadlines that you have to meet. There's so many other things that are going on that you can't risk not being organized. Like, you'll never make it. And I don't mean to sound like so dramatic in that, but there's just,
right.
There's so much, like, I honestly felt like as organized as I am in like a professional setting, I would leave work and be like, I feel like I got nothing done, even though I did, like, I know I did. And there's 4 million things I still have to do. I don't know that I ever left being like, got everything done, good for me. Like, it was like, there's still this to do. There's still this to do. It's just,
it's endless.
It's endless. Like, it's endless.
Yeah.
Much like life in some ways. Yeah. There's always laundry to do at least, right?
Yeah. So on that note, I was going to ask you, like, can you talk more about productivity and what that means? Because I think if you're not in community mental health, that word is quite foreign.
Yeah. I mean, I know productivity is a thing for my company specifically, and I believe our entire county, but I can only speak to my company that I worked for. But productivity is basically like, you had to meet a certain percentage or a certain number, I guess, of client contact / documentation per week, month. Why am I blanking now? I'm like, I've removed it from my head. I think it's per month. So it's like in the high 90s. So it's like the way the county and a lot of programs think about it is like, it's clients served. So like, it would be 5.5 billable hours per day that you had to meet if you're a full-time staff member, which sounds reasonable. Like, that's 5 clients and like 30 minutes of documentation. Now, where I argue so what's hard is that we're working with a population that is not always consistent. There's a lot of barriers to accessing mental health services, as well as the severity of the symptoms. These individuals might not always show. So you have to make up that 1 hour, or however many clients didn't show. In addition, it's such a high-paced atmosphere where, you're with somebody and then a crisis happens, but then the crisis bleeds into the next client. So you have to cancel the next client, and then you have a little bit of room. So then the doctor asks you to check in with the client for 15 minutes. And so while you're consistently busy, like, you're never not doing anything, you don't always meet this 5.5 hours. And then in addition to that, like, there's stuff that you're doing around the program that don't count. Faxing and doing like a brief check-in. If it doesn't meet certain standards, you can't bill for that with a client. And even when you're doing an assessment, like, the preparation and going through consent forms and those sorts of things, like, are not considered billable. So like, you're losing a lot of, like, you just can't account for a lot of the time that you are actively doing things. And so you have to keep that in mind. So I have a lot of animosity towards the productivity standards, because I also come from a place where I've had to write people up for not meeting productivity when they are excellent clinicians.
Mm-hmm.
And in my eyes, having somebody who is skilled with clients, who can meet people where they're at, is empathetic, uses adequate like interventions, is good with safety assessment and planning and coordination of care, is so much more valuable than just going through multiple clients. And I really struggled with that part.
Yeah. And I can imagine if you're so like you want to keep your job, you don't want to get written up and get fired. And I can imagine if you're more worried about, am I meeting productivity this week? You're not going to be as present and your mind's going to be elsewhere.
Yeah.
And I think just as a whole, a lot of people who get into this field aren't here or don't get into it because they're going to meet these really stringent requirements. It's, I want to be with clients, right? So it is kind of this structure that you have to learn how to work with if this is the population and this is the setting you want to be in. That is just one of the realities, right?
Yeah.
And it might not feel natural or be
Right.
natural even.
Absolutely.
Yeah. And I can imagine this being I mean, we all know we've been there, but for you, Kristen, you've been there longer. It's a really high stressful kind of job. And again, very fast paced, have to think on your toes, lots of crisis. What are some of the benefits of being in a setting like this? What are some of the pros of working in community mental health?
Yeah. I think that you get a really awesome experience with so many different people. You're going to experience people of many different backgrounds, ethnicities. You're going to have a lot of experience with many different diagnoses. Like, I don't think in, private practice, you might be exposed to somebody who has a diagnosis like schizophrenia or schizoaffective disorder, unless it's like very, very, very well managed. So I think that's really cool. Like, it was a really neat experience to be able to work with such complexities, because these individuals are also so resilient at the same time. Many of them are so resilient. So I really enjoyed that. Was it difficult as well? Absolutely. You get exposure to a lot of different trainings. We have different free trainings that we could attend throughout our time. We had required trainings as well on a yearly basis, having to do with like theories and law and ethics and all of that stuff as well. I think there's the benefit of a really tight-knit group. Part of what made it very difficult for me to leave was my team. My team was excellent. Like, we were a smaller team, so we got to know each other really well. You do so much collaboration amongst one another. There's therapists, there's a psychiatrist, there's one or more psychiatrists, a peer. Some programs have the case management component as well.
And I think that's the beauty of these agencies, right? Is well-rounded care.
Yeah. And then the front office staff, like, so you really get to know one another pretty well. And I think that's one of the best components. Other benefits.
Loan forgiveness is a big one.
Loan forgiveness is a big one. I believe it's like 10 years you have to be in it,
It's
though.
10 years. You don't need to be in the same company. So it
county or something like that.
Yeah, it has to be a nonprofit, county funded site or something like that. And then it just needs to add up to 10 years.
Yeah.
So there's a
Yeah,
loan forgiveness.
that could be a whole nother podcast. There are pros and cons to that as well.
Absolutely.
And sometimes there's talk of getting rid of it, and there's a lot of loopholes. So for those of you who are interested in loan forgiveness, do your homework. But it is a huge benefit, and a lot of people gravitate towards community mental health because of that.
Yeah.
So it is
just
something.
I want to expand a little more on the coordinating care and treatment team piece, because I think that is really the beauty of agency work and community mental health. That's something that I miss a lot now that I'm in private practice. I mean, I still get pieces here and there because we have our own consultation team and whatnot, but I miss like being in an actual, like, you know, building where I can walk across the hall if I had a quick question for the psychiatrist. I can use the office phone and call up the case manager and say, hey, I have a client that needs, basic hygiene products. Where can we find that? How can I get them connected to such and such services? I miss being able to call like the substance use counselor or therapist to ask questions about how this pertains to their presentation in this way. Like just those kind of things, like the collaboration amongst professionals of other relevant fields. I think that's really where the beauty comes from in these agencies, because it takes more than just, clinical therapy and mental health to really help someone struggling, like the clientele that you were seeing.
I think too, to kind of go off of that, I think the client might feel more comfortable, right? If it's, oh, I'm seeing these people in passing down the hall, or, after session, I can introduce them to Dr. Panicha, right? Before they leave, because they're going to have an evaluation with her 2 weeks from now. And she already
Right.
has, my client already has this familiar face, or I know who I'm going to meet with. So, I mean, it's kind of nice to be a one-stop shop in some regard, right?
Mm-hmm.
Yeah. I really liked that piece where, each week we would have a 2-hour meeting, and we would, support one another in helping to support the individuals we are working with. And it was really helpful to see, like, Joe didn't show to my appointment, have you met with that person recently, and kind of get a rundown of their presentation to help determine, what's the next course of action, how can we now best support this person, what's going on. So that collaboration amongst one another in the program was extraordinarily helpful. And we all come from different perspectives too, where, a psychiatrist is, has their perspective, a peer who's been through their own mental health treatment before has their perspective, and then as like therapists who are trained, in a different modality, we're all kind of putting in our input and working with each other to come up with solutions or interventions or resources to best meet the client's needs. And I did like that part. I mean, we really did try our best to do everything that we could within, our realm to help the person. And even sometimes, like, housing wasn't part of what we did when we can't bill for housing. We would still, try to find little loopholes in how we could help support them in figuring out strategies to, get housing needs met. Like,
Yeah.
it really felt like the team would go above and beyond at times.
That's amazing. So, on that note, are there other helpers aside from therapists? I know we've mentioned a couple, right? Psychiatrists and caseworkers, that other helpers that you think deserve a shout out in this field of community mental health?
The peer support specialists.
Mm-hmm.
I cannot talk highly enough about the peer that I worked with at my most recent program. Incredible, like, so resourceful, so knowledgeable, but always open to learning more and just such a kind human, and just brings such a unique perspective. I think, in community mental health, we're trained, don't put your experience or don't talk about your experience. And even just as therapists, we're told, that
Don't disclose.
Yeah, don't disclose anything. Whereas, and I understand the reason behind that completely, but I think it's very awesome that a peer does the complete opposite and shares their experience to what they're willing to or open to, because I feel like that helps somebody so much knowing that they're not alone.
Mm-hmm. And that's not available at every programs or agencies, I assume, like a peer support specialist.
I don't know.
Yeah.
At the ones I worked with, they were available. So I probably not, I would say.
Yeah, I don't think not every county funded program has that. Yeah.
Yeah. I'd say like the one that I see the most, like a helper that I see in most programs that don't get enough credit are like case managers. I know you did case management work as like the management position, but like someone that I'm particularly thinking of from the children's hospital that we were working at, like she was amazing, kind of like running around everywhere, and like you're really the go-to person for like 6-7 different professionals from one source in one place. I feel like they don't get enough shout outs as well.
I think another person who doesn't get enough credit is the nurses. So you have the psychiatrist, of course, that's prescribing the medications, but the nurse is really the one that's coordinating with the pharmacies. If there's a medical issue, typically
it's the
nurse is the one that's called in first.
Good point. Yeah.
They're the ones giving the injection medications like the Invega, Sustaina, and Abilify injections. Like, they have a lot of responsibilities in supporting the psychiatrist that I feel like a lot of people don't see.
Mm-hmm. Right. There's not enough of them. So, yeah.
Yeah. I mean, we had one for 400 plus, clients, same with psychiatrists, but the nurse's role was so integral. And honestly, we had a period where we didn't have a nurse, and it was the most stressful thing I could have imagined. Like, it was so stressful because I can't do certain things because of my license. Like, I don't have the ability to do like distribute medications for some people, but the doctor was too busy to do it. So like there's like this crazy like scrambling to try to fill that gap. So like they're so important in the community mental health setting. Those would be my two.
Yeah. We love all our helpers. They're all needed. And anyone in the helping field in general just doesn't get enough credit.
Yeah. I think some substance use, like AOD counselors and stuff too, right? I've seen some AOD counselors go above and beyond for clients and really connect with them on a completely different level. And I mean, I know we've done an episode on this already, but a lot of times they are included in like more community mental health settings. So, it's almost inspiring to see how they can connect with clients with using kind of some of that peer support pieces, right? Like that connection. So there is something to be said about sharing and disclosing. It's not all bad.
Our program didn't have a substance counselor, but I do think that would be an important role to fill or to have.
Yeah. Which kind of leads to our next question, right? If obviously you've worked in this field for quite some time. You're transitioning out to do other things. But is there some sort of systemic change or, policy that you feel like needs to happen in community work?
There's a lot of changes, in my opinion, that there needs to be. I think there's the issue
The big ones
of pay. In general, I've noticed that, pay is pretty minimal for what somebody in the community mental health setting is doing. I think not only do they, increasing pay just is needed because of the intensity of the work and the amount of education and everything that, a therapist or anybody else in the helping field has gone through. But it also helps to decrease turnover. High turnover is a complaint that I consistently received in the management role from clients when we did they were called PAG meetings, where we had clients come in and talk about changes they would want to see. And a consistent one was like, there's such a high turnover. Like, I just met with this therapist and then they quit, and then I got a new one and then it wasn't a good fit, so then I switched this one and then they quit. And that's really common to hear, and that's very consistent with community mental health work. So I think that's one of them. And you just think about the therapeutic relationship and how important it is to have somebody with you consistently. I think there's just a general need for more staff. I didn't touch on it all that much, but there was a point in my work where there was 2 of us in a management role, 1 full-time therapist, 1 psychiatrist, 1 nurse, and a peer for over 400 clients.
Oh my gosh.
And it's just not doable. It's
right.
That's not safe for a client. It's not safe for staff. And part of that, I think, also has to do with the pay, but also just positions available. Like, the program in and of itself is not that big anyways. So we need more staff, more therapists, maybe a crisis specialist.
More funding.
Yeah.
And that's what it comes down to, is a lot of these programs, they don't have the funding, even when management wants to pay you more.
Yeah.
Right.
No,
they don't have it in the budget.
Of course. Yeah. Exactly. Oh yeah. If it were up to me and I had the funding, I would increase people's pay tremendously, but I couldn't. I was bound by the contract we had with the county, and it was, to be quite frank, am I allowed to swear? It was shitty. I don't know.
Yeah. Yes, you can. We swear on the show. It's rated explicit.
And that was really, really frustrating to deal with, because we've lost people when I was hiring or trying to hire. They're like, are you kidding me? Like, I'm not going to work for that.